Good morning, ladies and gentlemen. Firstly, I would like to thank the chair for an overwhelming introduction, and also to the chairman of the scientific committee for this kind invitation. And they've also given me a challenging task, whether I'm going to faint in another 1.5 hours giving 4 marathon lectures. But my intention is to keep you awake for next 90 minutes, if possible. Coming to bone imaging plays an important role in nuclear medicine because, in fact, 30 to 40% of our workload is based on bone imaging. And I will try, in fact, this first talk is basics, which most of you will know, and I will just brush you as a part of the CME, but the main talks will come just after this talk, brushing more about what is the clinical applications of SPECT in benign and malignant bone disease. For the next 20 minutes, I will take you through incidence, pathophysiology, and radiological and radionuclide imaging, and touching a bit on breast and prostate cancer, and that's where the major work we often do in our general practice. Coming to the basics, bone is made up of cortical, tubercular, and marrow components. And in fact, the cortical bone and the tubercular bone consists of the same matrix and the cells with various proportions. And cortical bone is mainly calcified, up to 80%, and tubercular bone is about 20% calcified. And in fact, bone metastasis is a most common malignant tumor, and it involves in about 30 to 70% of the cancer patients, mostly involving lung, breast, and prostate, usually spread from medullary cavity into the cortex, and there's a combination. It could be sclerotic, lytic, or mixed. If there is bone metastasis, unfortunately, it's incurable. And if metastasis is present, the change becomes more of a palliative management rather than curative. Coming to the basics, normal remodeling of bone involves a balance between osteoclastic and osteoblastic activity. And bone metastasis, again, could spread by direct invasion, could be arterial, or it could be venous. Different factors account for it, and the commonest factors they account for it is a high blood flow to the marrow, production of molecules that bind to the tumor and the marrow cells. In fact, all these components come from what is called as a seed and soil hypothesis somewhere in the 18th century. People thought we should not concentrate only on the seed, but also on the soil where it tends to spread and where it tends to metastasize. And in fact, the mechanism is when the primary tumor is limited within the basement membrane, it's not that much a problem. But the primary tumor often secrete what is called as a matrix metalloproteins that helps to break the basement membrane. And once it comes out of the primary tumor, it is often protected by the platelets. In fact, the platelets mask them to evade the immune surveillance. And then the tumor cells are transported to specific sites. And based on the adhesion molecules in a particular area, the migration of the tumors start place and go into the bone marrow. And then they often multiply. And tumor cells often from the bone marrow will invade bone, and that's when the progression starts. Characteristics, you can have a combination of lytic metastasis, sclerotic, and mixed, but the lytic metastasis is based on parathyroid hormone-related protein, and transformation growth factors have been implicated as one of the main causes of transforming into lytic lesions. And again, all sclerosis is not bone metastasis. That's the basic teaching. If you go to radiology, you have to think in terms of other benign pathologies like bone alliance, Paget's disease, fibrous dysplasia, and osteomas can present as sclerotic lesions. So you need to be cautious not to overcall these scenarios if you're going in terms of cross-sectional imaging. Complications, it starts with a pathological fracture. You can have a spinal cord compression, you can have hypercalcemia, there may be pain. These are the things we have to take into consideration. And especially the risk of pathological fracture. Often we need to be quite careful in reporting patients with breast cancer. It's not a problem in most in prostate cancer patients because the sclerotic metastases are unlikely to fracture, but if it's a lytic metastasis, there is a more propensity to fracture. So therefore we have to look at the bone scans quite carefully and alert the clinicians whether there is a potential chance for any pathological fracture or an impending fracture, therefore they can take appropriate measures in these patients. Radiological imaging, whatever it is, the technology must have progressed to an MRI, but still we start with X-ray. It's easy, cheap, and easy to perform, but it takes at least 50% of bone destruction to become visible. And in fact, you can have a combination of lytic, sclerotic, and mixed pattern. Because of its poor sensitivity, you can't use it as a screening modality quite often, because now currently, though the technology is advanced, still bone scan can be used as a basic investigation for pain and follow-up of bone scans or radiographs in some places. Again, the practice may vary from different parts of the world. Coming to the CT has definitely a better soft tissue contrast resolution compared to an X-ray. It's widely available and it detects soft tissue disease, detects the presence of metastasis and also complications related to bone metastasis. It's useful in assessment of treatment response, and an appearance of new lesion is in keeping with progression, but if you see a lesion progressing from lytic to sclerosis, it means there is a healing response and it is not a progressive disease. So you have to be a little bit cautious about all these things when you are reporting, especially in the world of hybrid imaging. Less sensitive for bone marrow, and therefore we have to go for higher technology, and that's an MRI. It's useful for diagnosis, staging, follow-up of musculoskeletal pathology, definitely a greater soft tissue contrast. It detects bone marrow disease. But the problem is most of the departments will have about 10 CT scanners, but the number of available MRIs in the department to use it routinely for oncological and non-oncological practices, you may not get adequate slots, and often it gets delayed in treatment management. And therefore, MR is quite useful, but the availability plays an important role. So to summarize, what is the role of radiological imaging? It helps in detection, the presence and extent of metastasis. It helps assess the complications related to metastasis, and it is also useful in assessment of prognosis and treatment response in patients with malignancy. Radiological imaging, well, we have specific and non-specific radiotracers, but mostly I'll touch upon MDP, which has been used for the last 40 to 50 years. And there is a wide lot of experience, and we know the biodistribution, normal variants, and artifacts, what all related to the bone imaging using MDP. And it's widely available, it's highly sensitive, and all it requires is just a mere 10% change in the bone mineral turnover. You can see a positive scan. But the problem is specificity. Specificity, in fact, if you pull the literature for the last 30 to 40 years, in fact, it varies from about 2% to 70%, because especially the spine, often there's a combination of degenerative disease, and you can often get it wrong, which I will show in my SPECT talk. And people thought, okay, moving towards a SPECT technology will improve our sensitivity and specificity, but SPECT has not convincingly identified lesions which are not identified on planar images. So we need something more robust, close to 90% or 95%. So then came somewhere in 2004 and 2005, started with a single slice, and then they moved on to multi-slice SPECT technology. And the current literature, though there are about 20 to 30 papers related to SPECT in bone, all the papers tell that it is useful as an accurate localization, useful in characterization, it improves specificity, reduction of equivocal reports, but the only problem is there may be an additional radiational component. But also, what is more important is, as a nuclear medicine physician, it increases my confidence level to refute or confirm sinister or benign pathology in most cases. Coming to PET tracers, although most of the departments will use FDG, and fluoride is being implicated that is going to replace MDP bone scan, but there are challenges related to that. But I think I will explain why MDP bone scan still will remain for next 20 to 30 years. The reason they say fluoride is challenging and it's useful, it's because it's highly sensitive, and you get high quality images, less waiting time. And I think the more implications, a more important value of fluoride will be in quantitative assessment of bone metabolism. And that's where, for example, if you look at 2 super scans and the clinical question is it progressing or is improved, maybe by quantitative assessment we can tell, and people are working on some software programs to get a score. Based on that, we can say whether it's assessment or prognosis. But what are the problems if you switch on? It's a question of availability, and although we say PET-CT has revolutionized, they have done a survey within the European Union, and only 10% of the departments in the European Union has got PET-CT scanners. So still there is a potential role for nuclear medicine and MDP. Training to report scans, it's not as straightforward as MDP, because MDP we know the in and out, what are the problems you are facing. Because it is oversensitivity, you will pick up, you will over-report your scans if you're doing just the fluoride. Maybe with the fluoride PET-CT, you may have a better outcome, because what happens is if you're just doing a highly sensitive technique, all these enthesitis, enthesiopathies, all these muscle insertions show as an areas of increased uptake, especially in the ribs. So you can overestimate the disease burden in these patients. Throughput, how many departments have got the facilities to give a slot for a bone scan using fluoride? Because in my department, we do about 24 scans a day. With FDG, it's 2 scanners. We start around 8 o'clock, finishes at about 6:30 or 7 o'clock. But we have no slots. And in fact, even in the UK, very few centers use fluoride. And still, we are dependent on the MDP bone scans. And whenever we do fluoride, it is mostly for research purposes, especially fluoride and choline. It is still in the research phase in terms of cost effectiveness and other aspects. And also the cost is again a problem because you can do bone scan for half this cost. So who's going to pay for it is the question. And then comes the radiation. And again, you're going to give about 9 millisieverts if you're going to do a fluoride scan. But you can get away with about 4 to 5 if you're doing a SPECT scan. But with the fluoride, again, adding a SPECT component, a CT component, you're going to increase by 4 to 5 millisieverts, which is again going to be a problem, especially in a research scenario, because we are getting into newer trials where we do a bone scan every 3 months. Every 4 months, the patient has a bone scan as well as a CT scan. And if you're going to fry these patients with 15 millisievert for every 3 months, and that's going to be a problem. It's not going to be a problem from the imaging point of view, but our partners in practice, the radiologists, have an edge to promote MRI, which is going to be a gold standard. Because what all we are going to do, because there is a paper recently, about 2 weeks ago, which says MR can do everything. You don't need a bone scan, you don't need a PET scan and everything. It can change the whole way prostate imaging is, will change quite drastically. Coming to what is the major problem and flaws when they promoted fluoride as is better than MDP is they compared a 2-dimensional planar imaging with a 3-dimensional imaging. All the papers, even now, they say whole body scan was done, and it is compared with a fluoride scan. So naturally, a 2-dimensional imaging will give less number of lesions compared to your 3-dimensional because you're comparing a planar with tomography. Ideal studies, you should do a crossover study, do a MDP SPECT, compare with the fluoride. Maybe MDP SPECT will detect 300 lesions and a fluoride will detect 320 lesions. Then comes the question whether 300 versus 320, is there any impact in terms of management? So unless we develop evidence comparing like with like, you do a tomography, you compare MDP SPECT with a fluoride, and whatever the evidence comes out of it, there may be a justification saying that fluoride is definitely better than MDP imaging. And it's a famous statement by Professor Fogelman. Still, I clarified this even last week. I asked the same question because every meeting I go, they ask me the same question. What is the role of MDP bone scan in the era of PET scanning? And will fluoride scan replace MDP bone scan? And he says the potential problem is it's almost too sensitive, and one has to learn how to read a bone scan from the start again, because there are often many lesions present and potentially false positive due to minor degenerative changes. So you need a gap, you need a learning curve. You can't just switch off from MDP bone scan today and start your fluoride scan tomorrow. It's not going to work. You have to have a learning curve. You need to understand the normal variants and the pitfalls. And we have not experienced, though the fluoride tracer came somewhere in 1962, the technological advancement didn't match it for imaging, but now it's again regaining importance. But there will be a learning curve before we switch on. Coming to FDG and bone metastasis, as we know, it images bone tumor rather than non-specific osteoblastic response. Breast cancer, it's reported to be useful because you can assess both the lytic and the mixed pattern, and that's where it is promoted to be quite useful. Whereas in the prostate, because it's more of a sclerotic lesions, it's less sensitive than bone scan. And of course, there are other physiological challenges like urinary excretion of FDG, increased uptake in benign prostate pathologies, and also inflammation can show FDG uptake. So still, we need more evidence to say FDG is useful in this scenario. Myeloma, they say FDG is definitely better than bone scan because you identify early bone marrow disease. Choline is again gaining quite a lot of importance, at least few centers in the Europe. They are telling that F18 choline will play an important role in patients with prostate cancer. because it can detect both marrow disease and soft tissue component as well as the bone metastasis more effectively than any other bone modality in the future. Coming to the role of detecting bone metastasis in breast cancer, it's heterogeneous. You have several biological subtypes, and the clinical course is variable. It depends on, and also 8% of bone metastasis is seen in patients with breast cancer. And again, as the staging goes, you can see 70% of the patients with advanced cancer will have bone metastasis. And spine is the commonest site. In fact, nearly 30 to 50% of the patients will have bone metastasis in the spine, and half of which will be asymptomatic. And that's why you need adequate screening, adequate diagnosis before you start the management. And the guidelines vary because what all we practice in terms of bone imaging and other modalities, most of the investigation and papers are from the 80s and 90s, but the technology has moved, the treatment has moved, and still there are no definitive algorithms. Still it is challenging, and in practice varies. There is no one method where you can strictly say this has to be done. And it depends, again, at the end of the day, if your oncologist asks for a bone scan, you will do it irrespective of what the guideline says. So whether to perform bone scan in initial staging or in restaging or just in surveillance. But the evidence says the role of MDP bone scan in an early stage 1 and 2 is controversial. The positive rates are very small, but when it changes to 3 and 4, you can get a 7 to 47% of metastatic disease. And therefore, bone scan may be useful in that scenario, but not in the early stages. Preoperative, as I said, there is no indication if the tumor is in stage 1 or stage 2, and it's performed in all patients with 3+ stage. And any stage, if a patient comes to an oncology clinic, if he says he's got bone pain, he will get a bone scan. Irrespective, you might think clinically it could be degenerative, but you can't exclude bone metastasis, and therefore, any patients with stage 1 and 2 with clinical symptoms and raised alkaline phosphatase will get a bone scan. Post-operative scenario should be considered in patients with stage 4 or with 4 or more positive axillary nodes. In terms of follow-up, asymptomatic and symptomatic patients, some evidence again is controversial. Some say it is useful and some say it is not necessary and it's not cost-effective. And they have evaluated and they found that bone scan is justified only in patients with new symptoms. You can have a bone scan in the follow-up period. Assessment of response, any increase in lesion activity or in number of lesions with 6 months of systemic chemotherapy does not indicate any disease progression. And also, just reduction in uptake doesn't mean the patient is responding. There may be a very aggressive lytic disease continuing to progress without an osteoblastic response, and therefore you can what's it called underestimate the disease progression if you're not careful. So to summarize, what's the role of FDG in breast cancer? It's a direct tumor imaging agent. It detects osseous metastasis just before an osteoblastic response starts in. It's highly sensitive. It detects both osseous and non-osseous metastasis. Comparative accuracy with bone scintigraphy, restaging and response assessment, it is reported to be useful. So there is a role for SPECT and PET tracers in imaging patients with breast cancer. This is an example of a patient. Again, they publish papers like this. There is a whole body bone scan, and they show a fluoride scan, and they say fluoride detected 300 lesions more than the plain scan. But I would be happy if I see a SPECT bone scan showing 20 lesions and your fluoride scan showing 300 lesions, then I will accept that fluoride is the way forward. I will skip this. And coming to prostate cancer and bone metastasis, we know bone is the second most commonest site after lymph nodes in patients with prostate cancer. Approximately 10 to 20% of the newly diagnosed prostate cancer patients will have advanced local disease. Bone metastases are approximately found in about 10 to 30% of patients. What's the role of prostate cancer and bone imaging? There is, again, it varies from which part of the world you come from. But generally in the European scenario, it's not required in asymptomatic patients where the serum PSA is less than 10. Symptomatic patients with bone pain or low raised PSA levels will be recommended by the urologist because they did a national survey. If the patient is symptomatic, 70% of the urologists will ask for a bone scan. And also the negative predictive value, about nearly 100% if for a PSA less than 20, but you have to be cautious here. This negative predictive value is before the treatment. But once you start treatment, the whole concept changes on how we are going to use bone scan in this scenario. Post-operative, rising PSA correlates with a positive scan independently of other clinical variables, irrespective of whatever the pattern. If there is a rising PSA, patient will get a bone scan. Fluoride, high sensitivity, and often most of the centers who practice using fluoride imaging also do an FDG together, and a few centers in the Europe, prostate cancer patient usually gets an MDP bone scan followed by fluoride, followed by FDG, then followed by choline. So they'll have a series of 4 scans in patients with prostate cancer. But in the UK, that's not the scenario. We still are less, because there is quite a lot of evidence there. FDG is less sensitive except in aggressive tumors. And choline PET is sensitive for soft tissues. And the future, I think so, most of the papers are saying, choline, fluorine will be useful because it's upstages to bone and nodal metastasis. Possibly even if the PSA is less than 1, you use a FT, and they have picked up disease in such a low PSA levels. And bone marrow metastases are often negative on CT to start with. And in prostate cancer, FDG is less sensitive. So bone metastases are positive in FCH and fluoride, but the bone marrow metastasis will be positive only on fluorocholine. And also, it's quite interesting to start, if you start looking at the patient in an early spectrum, initially your choline study will be positive. Later on, your CT and a choline study will be positive. And when you start, when it becomes more sclerosed, in fact, there are quite a lot of studies done from a group in Austria, that if the bone becomes highly sclerosed, it turns into negativity on your bone scan. So though you can show as a metabolic response in terms of PET imaging, but there'll be morphological changes, morphological progression on the CT scans. And also, if you wait for a longer time, for example, if your Hounsfield unit is approximately around 1,000 plus, you're not going to see on any modalities. You're going to see only on the anatomical modalities, but not on the functional modalities, because there is no viable tissue there, and also the sclerosed bone is literally a concrete. There is no mechanism to induce an osteoblastic response in those areas. So you have to assess both the scenarios. Coming to the summary of role of imaging in bone metastasis, radionuclide, SPECT, and PET tracers are useful. Breast cancer, there is a role for SPECT and PET tracers, but prostate cancer, more and more departments are going towards fluorocholine and fluoride, and I think so that is going to be the future. But the question is whether fluoride is going to replace MDP. Maybe not now, because we have to increase the number of PET scanners around the globe, and because there is only 10%, as I said before. If there is availability, and if you have a space to do fluoride scans, it is quite good. But again, we need more validation, crossover studies. But the most challenging aspect is, even after 40 to 50 years of time, there is no single technique to tell which technique identifies metastasis first. So ideally, you should be doing a crossover study, starting with a whole body bone scan. When it's negative, you should go for a SPECT, or you can go for an MDP or a fluoride scan, followed by an MR and a CT. Thereby, we can say which agent or which technology, which technique helps in identifying the first metastasis, whether it's a marrow metastasis or it's a bone metastasis. But so far, there is no answer, because we have to use multiple modalities to come to a conclusion. So all those people who don't have PET-CT, you don't have to worry. There is still bone scan. You can do wonderful things. That's what I'm going to show in my next talk. There is scope for bone scan. You can do anything if you have passion. Technology is just a secondary. If you don't have passion, then technology plays an important role.